come to your mind, only 3 points that comes to your mind when you think about dengue fever. Three points. Let us see what you all think. Okay, when I think dengue fever in the ICU, okay, we're talking of dengue fever in the ICU. So what are the 3 points that come to your mind? And 3 points should be fast. It's not something that you require to write a thesis on. Okay. So done. Ali, what do you write? Very good. Sorry? Shock. Okay. ARDS. So she said ARDS, she said shock, and she said thrombocytopenia. Shalaka?
The
Hydration is important. Okay.
platelet transfusion not unless the platelet is less than 10,000.
Platelet transfusion. So you say this thrombocytopenia and platelet transfusion will be careful of. Right. Then?
And symptomatic treatment.
Symptomatic treatment. Chandrima?
Carried by Aedes mosquito.
Aedes mosquito. Okay.
Plague-borne fever.
Fever is there. Okay. Lot of plague-borne fever is there.
Petechiae and
Petechiae hemorrhages. Anybody else written anything else?
shock, renal failure.
Shock renal failure. So what we all basically are unifying is the fact that there is some kind of fever that comes in. We are all saying that there is some thrombocytopenia that comes in, and we all say that this is associated with some multi-system organ insufficiency. That is what you are saying. You are saying ARDS, you are saying renal insufficiency, you are saying requirement of fluids, you are saying platelets going down. So petechiae. So there is some kind of fever with the presence of something that is causing issues here, right? So if you think about dengue fever as there are how much times you can get fever with dengue in 1 year? 1 year. In 1 year. You probably can get 4 times. Because why? Because there are 4 serovirus. Dengue 1, dengue 2, dengue 3 and dengue 4. There are 4 serovirus. Okay, there are 4 serovirus. Where is dengue actually? Why are we discussing dengue so much? Because dengue is endemic. Dengue is endemic. Mosquito is endemic. Okay, it is one of the most dangerous kinds, and almost in an average year, maybe 5 lakh people all over the world die from dengue. Okay, and why is it a fever of the tropical areas? Because this mosquito remains between 35 degrees north and 35 degrees south. This mosquito. It is said that if you go above 1000 meters, you can't see this mosquito. This mosquito called as Aedes aegypti. It's called actually as Aedes aegypti and Aedes albopictus. There are 2 kinds of mosquitoes: Aedes aegypti and Aedes albopictus. They call them as tiger mosquitoes. You can look at them as tiger. They look like that. They look like tiger mosquitoes. Alright, so Aedes aegypti and Aedes albopictus. Now these mosquitoes are supposed to live between 35 degrees north and 35 degrees south. So the entire Latin America, the tropical zone, the subtropical zones are affected. It is said that the mosquitoes don't live above 1000 meters. However, India is a very unique country, so we get mosquitoes even at 2000 meters. Okay, but that's what the mosquito is all about. Okay, that's about the mosquito. Okay, it is this mosquito that has a cycle which is very similar to malaria, but very slightly uncomplicated, where mosquito host and mosquito. It's mosquito host and mosquito. That's the cycle. Mosquito feeds blood, puts in the virus inside. What kind of virus is this, by the way? It's an arbovirus. It's an arbovirus. Okay, it's an arbovirus. These are arboviral diseases, and that is the problem. The biggest problem here is it will mimic diseases that have kind of arbovirus picture, like a flavivirus picture. Which are those flavivirus pictures that you think about? You think about West Nile fever, you think about Japanese encephalitis, you think of yellow fever. These are 3 fevers that look very similar to a dengue fever. It's not arboviral, but we can say but actually looks very similar. That's why tropical diseases are actually put in one basket, because they look very, very similar. They look very, very similar. So when we discuss tropical diseases, we generally want to discuss the whole tropical diseases together, because they look very similar, very, very similar to each other. And dengue fever is something that is very unique. It's a very unique disease compared to the rest. Okay, because of the fact that there is no defined treatment. Malaria has got artesunate, scrub typhus has got doxycycline, but dengue fever has no treatment per se. So in short, when Shalaka says it's symptomatic treatment, she's right. There's only symptomatic treatment there. And there's not much. That is why this comes as a pure intensive care solution for us. It's a pure intensive care disease, like pancreatitis, no treatment. It is pure intensive care. You understand? So the disease is pure intensive care. That is the reason that when a patient comes into the ICU, there is no treatment apart from symptomatically management. And that's where the clinician's entire input comes in as to how to manage these patients. Clear on this? So tropical disease, 35 degrees north, 35 degrees south, all over the tropics, subtropic, Latin America, in all these places, are very badly affected. We are also endemic in this particular belt. That's why we Indians are popular in the tropical subtropical area. The disease has got a mosquito host mosquito cycle. It has 4 serovirus, dengue 1, 2, 3 and 4. They are essentially non-neurotropic. Ideally they should not get into the brain. Dengue 3 and 4 may sometimes get into the brain, very rarely. That's why they are essentially called non-neurotropic viruses. Non-neurotropic viruses. So when it comes to the brain, of course, you're looking at another serovirus coming, right? It's something like that. So you can get 4 types of dengue fevers, 1, 2 and 3 and 4 from the different serovirus that you have. Okay, and as you rightly said, the lab diagnosis becomes a little bit complicated, right? It becomes a little bit complicated. So let's go at the clinical features of dengue, okay, in the first place. Okay, so as you said, the virus, vector, and transmission is what you must understand. Okay, so what is it? So this is what it is. So the mosquito requires a virus. Day 5 onwards, up to date where lead feeds and transmits the virus, and that's when your illness starts. So the approximate incubation period is anywhere between 4 days to 20 days. It can be anywhere between 4 days to 20 days. It can be even 9 days, 10 days. Approximately 9 days is what the incubation period is for this illness to manifest. So after the mosquito bites you, in another 4 or 5 days time, or 5 days, and you can have a chance of getting dengue fever. Clear on this? That's the meaning of this. Okay. That is why whenever a patient comes into the ICU, the first thing you ask is essential travel history. I will travel to a zone which is not a hospital. Have you had a travel? The first thing. So we are a recent patient. Let's relate this particular one to the recent patient that was there in the ICU. Right? What was his history? You know that patient was there, that young guy who came into the ICU. What did he have a travel history? Yes, he had one. He had a travel history. He had 5 days ago visited his hometown for a period of around 4 days, which was grossly endemic in the interiors of Maharashtra. He had gone to the interiors of Maharashtra to some village which is endemic for dengue fever, which he also knows. You understand? So that essential travel history, all of you are missed. I knew it. I knew it. It was an essential travel history that you all missed. So it's important for you to actually take that history. Okay? Are you understanding? So why did you miss out this history? Because you probably don't know what dengue fever is all about. You should never miss out a travel history because as we said, the lab diagnosis becomes very difficult. The lab diagnosis is not easy, and that is why you need to be very certain about your travel history. Okay, your clinical manifestation, travel history, and then comes lab diagnosis. Just like leptospirosis. Okay, we are also in the same situation. Okay, so that patient has got a travel history. So you travel to an endemic zone, come back 4 days later, develop fever. Probably going to be dengue fever, one of the tropical diseases that you're going to have. You don't think of other things like pneumonia and neurosepsis at that time. This is probably going to be a tropical disease, and I need to figure out what kind of disease it is. Clear on this?
Yes.
So travel history becomes very, very important. Alright, so now when we think about so what is essentially going to happen? Mosquito is going to feed, transmit the virus. That virus is going to move into your lymphatics. In the lymphatics, it's going to multiply, and as it multiplies, gets into the blood. That is the viremic period. And once it gets into the viremic period, that's when your problem starts. That's the entire thinking. That is what is happening to you. Alright, that is what is happening to you. Lymphatics, blood, multiplication, viremic. Okay, this is what is going to happen. And all that happens because of dengue fever is related to this possibility only. Nothing else apart from this. Alright. So then what really occurs is to ask, what is the response? The response is this. Why we need to know the response? Is because this is how your lab diagnosis also comes. Alright. So what is the essential response? The moment you start developing dengue fever, it is your NS1 antigen, which is called as non-structural 1 antigen. Non-structural protein. NS is non-structural protein. There are 4 non-structural proteins and 7 structural proteins that are there in this particular virus. Okay, you are finding out the antigen. It is called as NS1 antigen, non-structural first antigen. Okay, NS1 antigen. So it is NS1 antigen that goes up immediately after the patient comes into dengue fever. That means if you want to really diagnose dengue in the first 3 or 4 days, what do you need to send? An NS1. Okay, then after some 3 or 4 days, we see the IgM going up. So that's why after 3 or 4 days we see the IgM going up. Unfortunately, this diagram is really not right. Okay, after this goes up, it remains up for a period of how much? 30 days. It will remain up for 30 days, up to 2 months for that matter, up to 60 days it can remain. 30 to 60 days it can remain up. So if you find a dengue, NS and IgM positive, it still doesn't mean it's dengue fever unless you have an epidemiological source and a real feature that says this. You got the point? Because it's not necessary that it is present dengue. Because IgM is positive, it can be positive for 30 days to 60 days. Clear? Huh? Clear? Easy? Huh? 30 days to 60 days. Right? No, clear coffee. All of us take it. IgM will remain elevated for a period of 30. You understand what the problem is? See, if you do an IgM, unless you have a clinical, you can't just. That's why it is irritating if somebody just sends a dengue in a patient who's coming to ICU and after 3 days you're sending dengue fever. When the patient does not have anything, patient does not have any feature. Why are you sending? So it happens very often. Some pan, some waste, dengue be waste. Doesn't make sense. You understand? Huh? So dengue IgM. What about IgG? IgG by definition is a chronic immunoglobulin, right? It remains. So it can remain for how long? Decades. It can remain for decades. For your entire life it can remain positive. Thank you very much. So then why do you want to do this IgG? You want to do this IgG just because that's how she mentioned. What did she say? This is very bad. You're right. Concern. You're on the secondary dengue. That is why it's with IgG. You want to know that whether this infection has come, gone and come again. If it's come, gone, come again, we know very well that these patients can do worse than otherwise. Are you understanding? So I will have a more objective look at this patient than the usual patient. The secondary dengue always can be dangerous. Another thing that also comes to my mind is, if I have secondary dengue, there is a possibility that I might not get my NS1 positive. It may become later. Because there is already antibodies that are working so hard that it doesn't allow the presentation of the NS1 antigen. You understand? So you make it, that's why I don't want to send my NS1 again. It may delay the coming of that NS1. You are understanding? So the lab diagnosis becomes a little bit complicated if by any chance patient has got second dengue. In rare cases, 10 to 20% cases.
So they have not got a cross security, the serotype.
They have. No, yes, they are cross immunity.
So if they get a secondary infection, it will be a second.
Yes, yes. So, but secondary infection per se, virus comes and goes. Problem is not because of the virus now. The problem is because of the immunity that it triggers. Like COVID. COVID comes, goes 5 days later, COVID is not 7 days later, COVID is not there, but what happens? ARDS. Similarly here also, dengue virus comes, goes. You understand? Comes, goes, but then it leaves behind a lot of traces of immunoglobulin that inflammation and causes problems. You understand it? So it's a very interesting thing. All these viruses are like that. It comes, goes, but then it leaves behind its entire thing, entire problem. It's not a bacteria. Bacteria goes, become fine. That's not how virus is. That's why viruses are more dangerous. Alright. So the IgG will remain up for decades. Alright. So if I want to actually diagnose it, I need to understand this movement. Okay, I need to understand. So it doesn't make sense if a patient comes to you and you immediately send an IgM. It doesn't make sense at all. Because it is not going to come positive. It is going to come positive only after fever has passed 3 days, 4 days. That is when you're going to send it, then it will come going to be positive. Patient has just come yesterday at fever, today got admitted, you do dengue, NS1, then you do IgM, IgG. It doesn't make sense, no. I can send a dengue, NS1. I may want to send a dengue, NS1, but I strongly believe if the patient still has a source, has been endemically, go to an endemic place, come back, travel history, says that I've got mosquito bites and having fever, and very classical symptoms, maybe after 3 days I'll repeat it again. And that 3rd or 4th day I'll send the entire panel, dengue, NS1, IgG and IgM. Are you understanding? I will not send my dengue panel on day 1. Clear on this? On day 1, if I want to diagnose it, probably they will never come on day 1, they will come on day 2 or day 3. I will know what is the dengue, NS1. Clear? So at times, if you have secondary dengue, IgG comes positive. So what do you do then? Day 4 you send, IgG has come positive. Now what? I think this probably he has had dengue in the past, but now it still looks like dengue to me. Let me repeat. So I repeat it. It's probably secondary dengue. That's why the lab diagnosis is getting a little bit muddled. And if I am clearly saying that this looks like dengue, let me repeat it again. Okay, so I'll repeat a second test. The sensitivity of this is 96%. So 4%, 4 people will miss still. It's not 100. You understand? It's not 100. It is 96%. So 4%, 4 people in 100 is going to miss, and those 4 people may be secondary dengue. So clear on this? Huh? Understood this till now? Huh? Simple. So now when I say clinical manifestations, so now you understand that really the tests are not as important as your history taking and your clinical manifestations. That is what is going to determine what you are dealing with. So what, Elizabeth, you feel would be the clinical manifestations of dengue fever? You're very good, but is there any characteristic of this fever? So because you will take a history, right? So you will have to understand whether this is fever. So good, but any characteristic of this fever? So the fever usually is sudden onset. It's not like it's a small fever, it went up and then it has. It comes as a high fever. It comes as a high fever. Unlike a bacterial fever, which will have first a fever of 99, 98, and then 100, and then it will go up to 100 and 101, over a period of 1 or 2 days. But what kind of fever this happens is suddenly you get a 102-degree fever. That's kind of the sudden onset of high grade fever. So when you ask the history of pyrexia, what should you be asking? Fever achanak sa aaya ki? That is what I asked them. When you hear what I am talking exactly of a picture in front of a patient. So this is what it is. Fever achanak sa chalo, achanak sa. कितना था 120 अचानक से 102 इससे पहले 99 ऐसा तो नहीं आया नहीं 102 that is what that patient had classically was that patient was so classical he said मैं तो ठीक था मेरा बुखार अचानक से चालू हुआ घर में गांव से आया घर पे आया अचानक से मेरा बुखार 4 दिन में चालू हो गया 102 अचानक से आ गया दवा खाया वो ठीक हो गया he didn't give a history that I was not feeling well then I had some fever then the fever went up then I took paracetamol अचानक से बुखार आया बुखार 102 था this is what he exactly told you understand so that characteristic of that fever is something that you must understand very very clearly okay and so when you actually classify this particular dengue you classify into 4 parts the first is see this is classification that was done by the Indian vector-borne disease program. Okay, there's something called National Vector-Borne Disease Program, which actually classified in 2009 and 2014. I don't see a differentiating classification. It holds good. I think we can still use it. Okay, which actually differentiated them into 4 parts. The 4 parts are these. Okay, you have undifferentiated fever, you have classic dengue fever, you have dengue hemorrhagic fever, and you have dengue shock syndrome. I don't see a reason why we should not use this. Okay, undifferentiated fever is usually 70% of your cases, 50% of your cases will be asymptomatic. No symptom at all. 50% of your cases will be asymptomatic. So that means to say 50% of us sitting in this hall will have a dengue IgG positive. 50% sitting in this hall will have a dengue IgG positive because it's absolutely asymptomatic. 50% will be asymptomatic. Another 20% will be the ones that are having undifferentiated fever, which doesn't require hospitalization in any way. Undifferentiated fever doesn't require hospitalization. That means this patient will at home get some paracetamol, drink some water and become fine. So now 20% of them will have undifferentiated fever, which just means that he can sit at home, drink some water, take some paracetamol and become fine. So what have you understood? That 50% in this hall would have been IgG positive, asymptomatic. Because we are in the tropics, in the subtropical area where this is going to occur, this is going to be there. We don't know how many mosquitoes build up in our lifetime. You understand? So that's how we are getting dengue, but we are not getting typical dengue. We are not getting fever. It's asymptomatic. Then you have undifferentiated fever, which I just now explained, and then you have dengue hemorrhagic fever and dengue shock syndrome. Now let's go to how they all look. Okay, so silent transmission, undifferentiated fever, most common. It just comes, goes, the fever comes and goes. Okay, it's as simple as that. The classical fever is the one that you mentioned. You have classically a fever that comes with extreme headache, with retroorbital pain, with prostration. That's what you call as undifferentiated. There may be a maculopapular rash. Okay, that is called as classical dengue fever. Once you say dengue hemorrhagic fever, then we have manifestations of hemorrhage. which includes petechiae, purpura. You'll have visible bleeding. Petechiae, purpura can happen in classical fever, dengue fever also. But here you have hemorrhagic manifestations, which includes visible bleeding. So you can't say there's a petechiae, so he's bleeding. No. You should have classical, you should have bleeding, real bleeding. Understand? Petechiae and ecchymosis can occur even with classical fever, hemorrhagic manifestation. But when you say dengue hemorrhagic fever, you classify them. These hemorrhagic manifestations involve thrombocytopenia, involve classical bleeding, involves a tourniquet as being positive over here. Okay? And when dengue shock syndrome comes in, you start patient having circulatory disturbances. The differential between this and this is circulatory disturbances. Where here your pulse pressure will become narrow, patient's systolic blood pressure will fall. Okay, all these things will occur here. Here, what is happening? Here, the difference is that you are actively hemorrhaging and actively leaking. Actively hemorrhaging and actively leaking. Clear on this? Clear on this? Are we clear? The differentiating factor between all of these. It's important that you understand this. Okay? So this is what tourniquet test is about. Now, it's a absolutely non-sensitive test. Okay, 40% of the cases will miss out. It is not positive. It is not specific. Not sensitive. Nothing. Is because in the tropical areas where you don't have setups for laboratory investigations like IgG, IgM, rural areas, people start resorting to this. But this is not something that is going to you have to do. You can do it because it's academically good, but it's only 50% sensitive. You understand? It will pick up only 50% of cases. What does it say? You take a tourniquet, apply the tourniquet on your hand, raise it up to half between the systolic and diastolic pressures, raise it up to half, leave it there for 5 minutes. After leave it there for 5 minutes, remove it out and check 1 square inch of your area. If 1 square inch you have more than 20 more petechiae forming, then we say that the tourniquet test is positive. Clear? Simple test, but it just tells me that you can do it. It will give you capillary fragility very well. Capillary fragility. It will give you capillary fragility very well. Clear? Not capillary fragility. However, sensitivity to diagnose dengue is only 50%. So this is not a great test to be done. That is why clinical features, epidemiology and laboratory test comes in picture. Right? So it looks like this. When you do it, the test looks like this. Okay, it generally looks like this. Alright? So there was one classification of dengue hemorrhagic fever also, which the WHO gave us. Now what it initially thought of was dengue fever classification. Now you have dengue hemorrhagic fever classification, which says these, where dengue fever was positive to be grade 1 dengue hemorrhagic fever. Okay, when we said started reading grade 2, okay, when the circulatory grade 3, I mean there's profound shock as a multi-organ failure, grade 4. So this was one of the classifications, and of course people say let's not pick up with these classifications per se, but I don't see a reason why we should not do it. Dengue 1, 2, 3, 4, it just gives you a good that dengue 3 and 4 have got a very high mortality. It just tells you that dengue 3 and 4 have got very, very high mortality. Once you have circulatory failure and profound shock, you go to a very, very high mortality is what it tells us. Right? Now, very rarely you can have dengue encephalitis. Very rarely. And this is what it is. You will have signs of meningitis, seizures, mental rigidity, headache, confusion, and limb paralysis. Right? Clear? So this means to say if a patient calls you up, say for example, Chandrima, I have called you, I am a patient of dengue. Alright? And you were at home, and I told you that I visited Latur and I was taken to forest and came back. And 4 days later I developed fever, it's very high grade, and I'm not okay. You're taking history from me, so I told you all these things, okay? You told me yesterday to do a dengue NS1 antigen because you strongly suspect that I have dengue. Okay? So I say, yeah, okay. I did it, I came positive, and I called you back. So I'm on the phone now. Okay, so Dr. Chandrima, my NS1 is positive. What will you do? What will be your conversation with me? For example, I am calling you. I am dengue NS1 positive. I am calling you. Okay, this is how it is going to be. You are a doctor after all. So somebody will call you. Somebody will tell you, I am NS1 positive. What are you going to ask? What are you going to do? Is there something you told you the history. I called you. You know my history. Huh?
Examine also.
I'm on the phone.
And ask about diet and
I told you I read it.
So only treatment practice.
What will you tell me? I am not going into treatment. I'm not going anywhere. I am having a conversation with you. I am a patient. Okay, I am calling you and I'm saying I am dengue NS1 positive.
so I felt that you get admitted to a hospital.
All dengue NS1, that means asymptomatic, symptomatic.
There is a bleeding tendency or if the patient is actively bleeding, and they tell them to get a CBC done.
So you wait for the CBC to come, basically. So see how it becomes. So how do you do this? How do you do it? So that's why you need to know something called as early warning signs. That's why you need to know early warning signs. So you are going to ask them these questions. If by any chance, if the patient is at home, because 70% are going to be treated at home, it is a 30% that get hospitalized, of which 10% are going to 2% are going to the ICU. So you need to understand which patient you want to hospitalize, right? You need to understand, that's a very important thing. If somebody calls you, you need to tell them कि बस hospital में आना है. Right? How do you tell them? You tell them based on the early warning signs. Okay, what are the early warning signs? You say abdominal pain, tenderness, clinically fluid accumulation, patient getting breathless, vomiting, abdominal pain. Okay, and then on examination you have 3-4 things in the laboratory that says a platelet count on the lower side. Okay, this is what you're going to look at. If this is the case, these are the warning signs. So this holds good even for patients in the wards. So in the wards, if you have a patient who is having dengue fever, you are admitted for a platelet count that is 10,000 in the wards. What you have to follow? Persistent vomiting, abdominal tenderness, some bleeding here and there, some laboratory feature that says there is dehydration in any way, okay, and a platelet count that is on the lower side, right? That's what the entire right. So now let's go to our patient. Why did I not get him here? That patient that came here, he called me. Why did I get him?
Platelet count was dropping, sir.
Okay.
And he had abdominal pain. He had vomiting also.
Can I treat him at
And he
home?
had lethargy.
Platelets I had seen later on. He came later on the platelet count. But is it abdominal pain? He had persistent vomiting. Because at that stage, what had really occurred is fever had gone. So now you must understand what happens to these patients. What is really occurring? What is occurring is this. What is occurring is at the start when the viremic period is going on, you have a fever. You have a fever. Okay. Once your viremic period has moved off, you actually go into a situation where there is a sudden shock. That is when you see all these problems: mucosal bleeding, leaky capillaries. Okay, this period is called the leaky phase, capillary leak phase. So it is usually a viremic phase, a febrile viremic phase, a capillary leaky phase, and a convalescent phase. Okay, now it is important for you to pick up this patient right here. Okay, it's important because this is the time when the fever is gone. Viremia causes fever, there is no viremia. But the moment this patient starts having all these signs and symptoms, means he's going into this phase, it's important to pick him up here. Treat him right here. Right? Manage him right here. And this creates all the confusion that we have in dengue fever. Because when he comes into this phase, there is a possibility he may go to dengue hemorrhagic fever, there is a possibility he may go to dengue shock syndrome. Okay? Now here you will do everything possible to resuscitate this guy. You give fluid, you give blood, you give platelets, and then this is shortly followed in a 2-3 days time, shortly followed by the convalescent period, where you are seeing the complications that are occurring because everything that you have given is now coming back inside. So there will be increase in fluid. You understand, increase in fluid which is going to cause the patient to get better. So you can't over or under resuscitate your patient in this phase. Are you understanding? Because there is a very small line between over and under. That's why you must be very careful when you are actually doing the resuscitation for dengue fever. You got the point? You have to be very careful because you over resuscitate, then this in the consolidated recovery period, all that is going to get into your body and patient will start getting more and more breathless, more and more fluid overloaded, more and more ready and things like that. right? At the same time, you have to resuscitate also because otherwise you go to circulatory failure. That's why you must be. That's why your clinician works very well during this period. It's a clinician's job at this stage to understand how much fluid to give, how much fluid to give, all these things. So also what you must understand in this phase is the laboratory features that changes. Now let us go back to our patient. He had a laboratory feature that came in. What was the laboratory features that you saw on him at this time? The laboratory features that he had. And I also mentioned it during the rounds actually. I mentioned during the rounds also. What did you see? Because I got only thrombocytopenia from you guys. What else was there? There were 2-3 more important things that came in. Patient had presence of atypical lymphocytes. Patient had the presence of atypical lymphocytes which came over here. Patient had a urine albumin and occult blood positive. Patient had a urine albumin and occult blood positive. You remember I mentioning this during my rounds? Patient has an albumin. Why should a 29-year-old chap have albumin positive? Why should a 29-year-old chap have leukocytes, have occult blood positive? It is not possible, right? Albumin should not come in. Why is that coming in? Because he's getting into this phase. He's getting into this phase. Are you understanding? And that is what I did the moment he came in. What did I do my maximum time on? On finding out what is happening. Either हाथ में लगा के, whether he is having splenomegaly, whether he is having fluid, has he gone into the phase where the capillary leak has started? Somewhere in this phase has capillary. I wanted to find out whether he is going to capillary leak. So I was looking at the ultrasound at least for quite a number of time because I want to be certain before I start my fluids. Before I start my fluids, I wanted to be certain what am I dealing with. So if this patient already had circulatory leak, I would probably not even give a drop of fluid. I would have just waited until the BP actually fell. You understand? But here, that patient, I saw there was no capillary leak. He was just getting into this period. He had atypical lymphocytes. He had platelets on the lower side. He already had manifested with albumin in the urine and presence of blood in the urine. And he had a small petechiae here and there under his tongue. So he was between dengue hemorrhagic fever, grade 2, and shock. This was what he was in. He was a grade 3. Why is it grade 3? Yes, he had the presence of all these things. That's why he was a grade 3. So by classification he was a grade 3, which warrants ICU admission. That is why when he came to see me, what did I do? Admitted in the ICU. Are you understanding? Patient is normal. Remember this. These patients they will talk to you normally. These patients will not manifest like how your pneumonia patients are going to be. It's not going to be that septic, bacterial sepsis. They will be normal to you. They look completely normal. It is just a matter of 2 days when they will die. It is a matter of 2 days. These are only 2 days when they will die. You understand? So when does that coincide? Usually when the fever goes down, when the valve pill gets over. That is exactly what his history was. What was history? Fever तो फिर आप भी कल ही गया. कल से मेरे को fever नहीं है. That is when your period of shock, of bleeding, of all these things come in place. Are you understanding? समझ में आया तुम लोगों को? Clear on this? So now you know the laboratory features. Viremia, IgG, IgM going up, IgG and IgM persisting. Now it becomes very simple, right? So when am I going to think that this patient is coming out of this phase? When his platelets probably remain the same or starts rising. That comes to a question. What happens to platelets? Why are they going down? So also there was one more important sign on him. There was a drop in albumin. Okay, that also you should have seen. Albumin was 2.9 on his case. Because of leaky capillaries. So there was a albumin that was 2.9. Along with that, laboratory showed SGOT, SGPT on the higher side. But I was not worried about the LFT. Why? Because I am worried only if the SGOT, SGPT was more than thousands. It was not more than 1,000. So it was not more than 1,000. So I was not really worried about that. There is going to be some hepatitis, but not up to 1,000. That's fine. Okay. What are those platelets? What exactly is happening to platelets at this moment? What is happening? Platelets are going down. Why is it occurring? There are multiple reasons why this is happening. Number one is that there is a bone marrow depression in some way, which is causing this to go down. The second thing is that these platelets are going down because the most important reason is the reason that these patients are having von Willebrand factors is there now. The von Willebrand factors. You know how they form a plot and all von Willebrand factors. There is Adam TS13 which cleans these factors, and that's why they don't form multimers. Von Willebrand factor comes, it's in the endothelium. Okay, so von Willebrand factor comes together, they get attached. Then one upon one they get attached platelets and all, and then von Willebrand factor gets cleaved by Adam TS13, and then it doesn't form these multimers. What happens unfortunately in this is there is a reduction of Adam TS13 is what they found out. Okay, so because there is a reduction of Adam TS13, what is happening is that the multimers of von Willebrand factors remain. They don't get cleaved. They remain the way they are and attached to the endothelium of the cell of the vessel. Okay, what happens because of that? Platelets get stopped. Consumption of platelets are occurring. Circulatory damage occurs. That's why your microcirculatory insufficiency causes multi-organ insufficiency. So platelets are getting consumed. Right? Platelets are getting consumed. You know this? Huh? That's why the platelets are going low. We're worried about that. That is the proposed reason that that is why it is proposed that there is an immunological mechanism there. It is proposed an immunological mechanism here which is causing the Adam TS13 to go down, creating von Willebrand factor multimers and platelets getting stuck to the endothelium. Clear? That is the reason that sometimes what happens is you are a patient, you give platelets, if they don't come up, you give plasma comes up sometimes. What is happening? You give plasma, Adam TS13 is going inside. When Adam TS13 is going inside, what is happening? The von Willebrand factor is breaking off. And when that is occurring, platelets are actually getting freed out, and you can see platelets actually coming out. Are you understanding? So that's why there is a proposed immunological reason for all these things, and that is the reason that people do a lot of other things like plasma exchange. People try plasma exchange in these cases because plasma exchange is plasma protein plasma which are Adam TS13. Okay, so there have been trials that have looked at plasma. The reason is they understood that this may be the reason for that. Someone manner? Clear? Clear on that? Huh? Right. So the signs of any hemorrhagic fever would be definitely all these things. Is exactly what he was having. What was he having? Abdominal pain, which was intense and sustained. He said, persistent vomiting, which he had. He had an abrupt change of fever to hypothermia. 95. You saw the fever and told me it was 95. If someone saw the fever of this patient, I told me 95. It was cold. Now I told me hypothermia. Sweating process, restlessness. This is what he had. Restlessness. He has started coming with restlessness. Right? He was restless yet become. Okay. So he had all features that actually pointed him towards dengue, all the symptoms that point to dengue hemorrhagic fever. So that's why these are the criteria of dengue hemorrhagic fever. That is the alarm signal that we talked about. When patients develop dengue 3 to 6 days after onset of symptoms and initial warning sign and disappearance of fever, drop in platelet count and increase in hematocrit. The increase of 20% of the hematocrit becomes very, very important. That is exactly what happened to him. Then his hemoglobin went from 13 to 16, 17. You see his hematocrit what it was 17. So the entire thinking is this patient is in dengue hemorrhagic fever and we need to now resuscitate him adequately. That's why this was one of the few patients where we gave IV fluids on a maintenance basis. What is it? So we gave it on maintenance basis. You got the point how it all worked? Why and what did that do? By maintenance fluids I kept the microcirculation on. When I kept the microcirculation on, the chances of having multi-organ failure actually came down. You understand? It's as simple as that. Alright? So this is how you basically look at it. Importantly, the pulse pressure. Pulse pressure here. Is it there? Here. So this is a very important sign that you should pick up. Okay, the narrow pulse pressure. That is, it will be BP 100 by 90, 100 by 80. ऐसे सब BP मिलेगा. In this phase, because suddenly what will happen is 120, 80. This is, as I told you, 2 days work. In 1 day you will be normal, second day you will be in shock. Okay, so you have to pick it up early. Yesterday's BP was 120 by 80, today it is 120 by 100. So the pulse pressure becomes narrower. Pulse pressure becomes narrower. So very important sign that you should never miss. And then it goes on to systolic blood pressure going down, then goes on to unrecordable blood pressures. That is very, very important. That's why touching skin becomes very, very important in this. You touch skin, you'll understand many things over here. Right? Clear this? Yeah. So this is something that is not really specific for dengue. It is specific for any shock that you think of, circulatory shock. Okay, in any circulatory shock, pulse will become feeble, the pulse pressure will become narrow. Okay, this is something that is and then it becomes unrecordable, isn't it? So they basically there has been algorithm that they said that has been said to be used at least in the peripheries. We don't use it here because we have ultrasound, we have all of these things. but in the periphery, what do they do? What you can do also is you start the patient on a very high dose of fluid. Okay, fluid resuscitation, isotonic resuscitation. You see this maybe around a liter. How liter of fluid is going inside. Then you see whether there is improvement. Okay, if there is improvement, you just keep it at. That's what we did with it. We gave him a liter of capillite, and then we kept him at a continuous fluid of 120, 130, 100 per hour, and we kept it on that. We reduced it because he was okay. So we kept it on 100 per hour. Right? Then what did we do? We actually saw him getting improved, so we were really, really happy. He said, it's okay, I did a hemoglobin in the night. If you remember, I did the CBC in the night. What was I looking at? I was looking at hematocrit. Okay, hematocrit actually came down. So I am comfortable that it's fine. So then I said, don't worry. Are you understanding? So what did I do? I looked at hematocrit. If the hematocrit went down, if the hematocrit became normal, then it was stable, and when increase consider bolus fluid, decrease in consider transfusion over whole blood transfusion, others stop at 48 hours. This is exactly what happened. So hematocrit is what people follow to actually figure out what is happening. Okay, so you can actually do a repeat hematocrit. If it goes higher, rebolus. But this is a very naive way to do it. We have ultrasound, we are more qualified in doing all of these things, so it's easy for us. But this is what we do in the periphery, which is not bad. But this is what we do in the periphery because CBC होता है वहाँ. CBC hematocrit होता है वहाँ. You understand? So they're able to do this. So hematocrit goes up, you give another bolus. If the hematocrit goes down, you think and the patient is in shock, then you're looking at blood draw. Isn't it? If the hematocrit goes down and the patient is in shock and he is not improving, probably there is blood draw. That's the type of blood. Therefore, we follow the hematocrit. Clear on this? Have you understood? So it's actually simple. You understood now? So what will you do? For these patients listen to you. Say the patient has come in to you. Patient has got dengue, emergency fever with early morning signs with pulse pressure that's narrow. Now what will you do?
We'll see that the patient is clinical incubation, whether it is dehydration or it is in coma.
You know most probably that by time limits and by the way he is, that he is probably going in shock, pulse pressure has got narrow. What will you do next? You will immediately see for whether capillary leak. He is going to die. What are you going to give? Bolus the fluid. There is leak or no leak. Bolus the fluid. And then the next step is what? Shock. Are you understand? I will bolus the fluid and keep a watch what is happening. Are you understanding? I'll keep a watch. Then what do you do? So you start at say 100 per hour. Then you repeat a CBC. Look, follow your hematocrit, follow your clinical features, follow your ultrasound. If I find that, then you have to tailor it according to what happens. If she leaks further, I will think whether I need to give more fluid or not. I will think hard what I must do, whether I should put an NORAD, what I should do. You understand? But you first bolus. Crystalloids are important to be given. Okay, and then after that you take it from there. You understand? You can't not bolus the patient. You cannot not bolus the patient because these patients, if the pulse pressure is low, he is going in shock. He is going in shock. His pulse pressure was 100 by 80 when he came in. When he came in, it was 100 by 80. So, that was a classical case that survived and went. Say, if he was in another hospital, people are saying, next day, patient will be in hemorrhagic fever, will be in shock, will be in spontaneous bleeding. You are understanding? You are understanding? So, just we caught him early, we resuscitated him early, that's why he improved. That's what I am putting it as. You got the point. So, catching that patient would have been difficult if you don't know these things. If you don't know early morning signs, if you don't know what you're expecting, if the patient has fever comes, then comes below the you say, what's happening? Are you understanding? What do you understand? अरे नहीं भाई ये dengue hemolytic fever है तुमको इसको resuscitate करना है. Are you understanding? You got the difference? Okay.
So this hematocrit is like it's basically a marker for tissue perfusion is
for almost pediatrics as well. So pediatric dengue is very common. So pediatrics are used like this. Pediatric dengue is very, very common. So if the hematocrit goes up, it's obvious that you're concentrating your blood. That means the plasma is reduced. There is a leak happening. So you need more fluids. The entire thing is try to keep the circulatory system on. The day your circulatory system falls, you you are going to multi-failure because already there is microcirculatory disturbance because the 1 molecular factor multiplexer are formed. Clear? Huh? Alright. Now, what about blood transfusion? So, you do keep blood transfusion. Okay, you can't omit that. You give blood transfusion in these cases. What about platelets? That's the good question. What about platelets? What about platelets? So if it is less than 10,000, actually what the guidelines is to 5,000. However, it is impossible to wait till 5,000. If it is less than 10,000, the patient has got signs that patient may bleed. Okay, then you probably need to give them platelets. Okay, if it is less than 20,000, patient has peptic ulcer disease or chances of bleeding because of being on antiplatelets or something like that, then you still give him platelets. Okay. Clear on this? If the patient is pregnant, you will probably want to give platelets. Clear? There are a few things that comes to your mind. Okay. So less than 10,000, the incidence of spontaneous bleed goes up only less than 5,000. Okay. However, less than 10,000, you probably don't want to wait much. You probably give the platelets. How much platelets do you give? How much? Come on, Ashok. Give a number, how much platelets you want to give? So classically platelets are given in groups. It can be either RDP or it can be SDP. What is the difference RDP and SDP, Ruchika? What is the difference between RDP and SDP? What is the full form RDP? Huh? SDP?
Single donor.
What is the difference?
So this is from a single blood.
Okay, single blood donor and one platelet will increase your platelet by how much?
In single donor.
No, I'm talking RDP. Yes, so it is 5 to 8,000. It is 5 to 8,000. So if I want to increase my platelet to about 20,000, I need to give at least 5 or 6. No, 5 or 6. So 5 into 5 is 30,000. अगर मैं 10,000 में मेरे को 40 तक लाना है, हाँ? 6 RDP. That's why conventionally we give 6 RDPs. You understand? 6 RDPs or 1 thing. You understand? 1 RDP will have somewhere around 50 to 100 billion platelets. 50 to 100 billion platelets. But however, when you put it in the body, you measure and you see how much platelets going inside. It's 5,000 per microliter. 5,000 per microliter will go inside your body if it goes inside. 5,000 microliter. So if you want to make it 5 into 4 or 5 into 5, it becomes 25,000 microliters. You know, 25,000. That's why it should go by 30,000 up. So that's why we give 6 RDPs. Clear? 6 RDPs. And how do you check that? So it is within 1 hour your platelets will go up to this level. Within
1 hour.
Within 1 hour. Okay. So if you are going to do, if you are thinking of dengue hemorrhagic fever and you want to check your platelets on a regular basis, I can check it in 1 hour. Within 1 hour, after 1 hour, I can check it. Upar gaya kya? Are you understanding? More often than not, if this ADAM-TS13 system is working, it will not go up. If this ADAM-TS13 is our theory of dengue fever, it will not go up. That is why when I asked you the other day when you gave platelets, what happened? I asked you a term called as corrected count incremental. I asked him what happens. What do you do at 1 hour and at 24 hours? So at 1 hour, if it has not gone up at 1 hour, means there is some active mechanism, something like TDP, something like thrombotic thrombocytopenic program, where you give platelets, it will not go up, it will just get consumed. So so at 1 hour, if it just doesn't go up, it means it's some active TDP. because आगे प्लेटलेट देख तुम क्या दे रहे हो, खाली उसको एनर्जी दे रहे हो. आगे प्लेटलेट क्या कर रहे हो, खाली एनर्जी दे रहे हो उसको. Because platelets have got 200 to 500 ml of plasma, 200 to 300 ml of plasma. This plasma is taken from different people. They are proteins after all. They will cause allergic reaction in a good proportion of patients. That's why platelets also have leukocytes. Leukocytes causes febrile hemolytic reactions. Febrile reactions. So these leukocytes, this plasma, it is this that we want to avoid in platelets. That's why we want to give a SDP. Where the plasma content is low, where you are not giving in 5, giving 1. So just the leukocytes are low. Are you understanding? And there is ABO compatibility. Many times if you want to do it, it might also help. Okay, if you want to do EBO compatibility, it might do. That's why SGP and RDP. Clear on this? Have you understood platelets? Huh? That is why the platelets are 20,000. What do you do? I quickly repeat it. I want to repeat it. I don't want to. I want to be certain that the platelets are remaining at 2028. So the second time you was at 28. We didn't give you. 28 का नीचे slate it. Nothing happened. Again then we did it. Then it came to 38. 30. Then it went to 86. Are you understanding? Huh? Normally the rise of platelets will coincide with the viremic period moving off and the fever going down. You understand? Huh? The viremic period moving off and the fever going down. That's the day 5, day 6. Viremic period is over. You know, that is when it is. That's why you wait. आ जाएगा ऊपर. Clear? No. You can give SGP to the RDP. If I ask what I want SGP. Why? I don't want those antibodies. I don't want those plasmas. I don't want somebody else's proteins. I don't want to get a transfusion reaction in the smallest of the cells also. So if I can afford it, I'll afford SGP. No? if I want to give it to my own relative, मैं बोलेगा SGP दे दो यार, क्यों उसको प्लाज्मा किसी और को देना है? Because अगर हुआ रिएक्शन तो खराब रिएक्शन होगा. क्यों? If you have the presence of money and you have SGP, give SGP. Are you understanding? Huh? It's only that people don't have the money, that's why we give RDPs. Now RDPs can have this problem of hemolytic reactions. It has got all these transfusion-related problems. You've got circulatory overload because you're giving 200. 5, 6, 6 to 1,200 everything will need that only. You will not know whether it is circulatory overload or transfusion injury here. You are understanding? Huh? Which of that will not know? There is no fluid there. Fluid will be there. You are understanding? Are you clear? What I am saying? So this is not a problem that occurs. At day 6, day 7, patient is actually improving. Patient is not having symptoms of pulse pressure variation. Patient is not having cold clammy extremities. But platelets are 35,000. So उसको platelet दे दो. अरे क्यों दे रहे हैं? Because this is now the consolidative phase. You give the platelets, this can probably get absorbed back into the circulation, cause fluid overload. This is a period when convalescence is occurring. All the water that is leaked out is now coming inside. Don't give the platelet there. You are just adding insult to injury because we know spontaneous bleeding occurs when? Unless the patient has got active peptic ulcer disease or something like that. Clear? Huh? So these are very unusual presentations. Encephalopathy, as I told you. Why is it unusual? Because it's essentially a non-neurotropic virus. Hepatic damage, very rare. Okay, SGP means more than 1,000 will come down. It is viral, it is going to come down. Inflammatory reaction is going to come down. They don't really cause this. Very rarely cardiomyopathy and very rarely you have severe GI hemorrhages. Right? So pre-existing anti-dengue antibodies, previous infection, better antibodies and infections, that can make it more difficult. These are the risk factors. That's why secondary dengue. Secondary dengue is a risk factor for dengue, pneumococcal fever. See that? Age, of course, when you're older, there is a chance of having all this problem. And the dengue 3 and dengue 4 are supposed to be a little bit more dangerous compared to dengue 1 and dengue 2. Okay? Heparin before most serotypes, 2 or 3 together comes in. Okay, that is something like this. So dengue this is greater for dengue 2, 4 for dengue 4 and dengue 1. Okay, so obviously I am going to get blood pressure, evidence of bleeding, hypertension, increased vascular permeability, this is something you cannot omit. Something you just can't omit. You have to look at medication, which is obviously the legs, ankles, shins. Okay, you are going to send these investigations regularly because CBC I am looking at WBC because when the fever goes down, when the leukopenia moves off, that is when the patient starts kind of improving. Leukopenia will be the starting. There will be leukopenia. Okay, to be starting with. There's going to be little leukopenia that is going to occur. Then after the patient comes into the stage 2 where the patient can have a problem and the fever goes off, you're going to see relative atypical lymphocytosis. So leukopenia will be replaced by lymphocytosis. Okay, you have lymphocytes going on, you have atypical lymphocytosis. That's why WBC becomes very important for you. To see hematocrit, to see atypical lymphocytes, to see leukopenia, to see lymphocytosis, and to see platelet count. All of these things will come over here in the WBC count, right? Albumin, why? Because we just now discussed, the albumin is going to leak out. So a low albumin is a portender and a poor prognosis for dengue hemorrhagic fever, dengue shock syndrome. Okay, not dengue hemorrhagic, dengue shock syndrome, because if you have low albumin, you can assume that he's leaking out. He's leaking out. Okay, that's why low albumin there. Liver function test, because we know it's one of the early warning signs. If SGOT, SGPT goes more than thousands, it's an early warning sign. SGOT, SGPT going more than thousands is an early warning sign. That's why liver function test becomes very, very important. Urine check. This is exactly what that patient had. Microscopic hematuria. They actually portrays towards the problem that this patient is probably going to go to DHF or DSS. Right? And then your dengue specific tests. Very rarely, very few places in the world actually do virus isolation. When you say virus isolation, you are culturing the virus outside. Very rarely, but that is the diagnosis. If you think about it, that is the diagnosis. If you do virus and you see the virus inside, it is a diagnosis. But very few people do virus isolation. We all do serology. So I once attended one lecture. So this serology becomes tricky because we are doing IgG, IgM, and NS1. Now you understood what to do where. But there is one test called the dengue day 1 test. I hope that comes in very quickly. It's developed by Abdul Kalam. At one stage, Abdul Kalam made them do this when he was alive. Abdul Kalam actually called the ICGB, International something Indian something genetic something. So this is a group of people scientists who sit across and try to solve major issues in the world. So Abdul Kalam, it's a story, actual story. Abdul Kalam went and told them that you have to make, and they are not doing tests. They are doing something else only. They are making medicines. They are not making tests. So Abdul Kalam went and told the owner of that the president of that particular foundation, ICGB, which is part of the Indian government. Okay, he visited them in their setup, which was phenomenal, north side there, and he told them, I wanted to prepare a test because he knows the importance. Abdul Kalam knows the importance that if I diagnose dengue on day 1, I can prevent death. Because this is a rural problem. This is a problem of the tropics. This is a major problem. People are dying. People are dying. So if I get the problem to begin with, I can start the ORS. I can start these supplements of water to these babies and to these adults. Because in the periphery, I can prevent it by giving fluid hydration properly. But for that, I need the diagnosis. So what happens in the rural area? The next PHC is like 100 kilometers away. The next PHC is 100 kilometers. Have you gone to such places? Have you worked? Many of you may be staying also in such places. Okay, where the next PHC is like 100 kilometers away. If you want to go there, you have to take a train or a bus or a car or something like that to go so far away. You understand? So they will come to you, you will examine, then you will say, go home and do the dengue. It's very difficult, right? You need something that you can do right at that moment on day 1 that the patient comes to fever. Right? So Abdul Kalam understood this. Abdul Kalam is a very, very foresighted individual. He has so much of knowledge. Oh my God, if you read his books and all, you realize that guy, I see him president. It's like that. He was one of the biggest guys I fantastic guy. Okay. So he knew that if I were to get a test in place, I will be able to solve a lot of mortality and be able to solve a lot of people. So he went to ICG and he told them, I want to develop a test. So the president said, we don't do tests here. The story goes, the president, he said, we don't do tests. So Abdul Kalam went back home with the okay. He was a very humble guy. He went back home and then he spoke to his office and he said, I strongly believe we should get that test done, and they are the only people who can do it because they have the knowledge and know how to do it. So then what happened? The president's office called up them and told them, either you do this or we shut it down. Okay, that's the story. So they went ahead prior to COVID, 2 years prior to COVID, and they generated that test called as day 1 test. That test is called day 1, dengue day 1. Okay. Unfortunately, COVID came. And that test is no longer there. So now it will come back. We are waiting for that COVID to go out so that they can start doing these tests. You understand? They can start doing this test on that day 1 test. Because you can imagine the mortality change that you get. So on day 1, they've got a test which looks at NS1, IgM, IgG. All 3 together. So you get the diagnosis there whether it is primary dengue, secondary dengue, or whether it is not dengue. Are you understanding? Tabhi you get the answer. So patient comes, you put a lateral flow just like how we are doing these COVID tests. Lateral flow put a test, see those lines. If the lines come in, you say it is IgG, IgM or NS1. And you start treating. You understand? So that is something that is coming. So dengue specific tests. So maybe in the future you see that coming in very quickly. Day 1 for day 1. It was actually given to a company called Sun Pharma, which was earlier called the vaccine. They actually helped up and gave all the money to do that test. That test should come out, I feel. Alright. So this in short is what happens with the temperature. Okay. So you do have when the virus is there in the body, viremia is something very high. That is when you have the fever also going to be on the higher side. Fever is on the higher side. When the virus goes down, that is when the fever goes down, and that is when the serology starts getting positive. Simple, simple, very simple. So in short, this is what the criteria is. But however, I would not able to look at it as just like this. You have to have a clinical know-how here. If you have dengue plus bleeding, dengue hemorrhagic fever. If you have dengue hemorrhagic fever, it can kill. This is some misconceptions I'm telling you. These are the misconceptions. Okay. So dengue plus bleeding does not mean dengue hemorrhagic fever. You should have platelets, you should have capillary leak, you should have all those things coming in. Are you understanding? So don't categorize everybody as dengue hemorrhagic fever just because they are bleeding. You understand? They might bleed just because they are low platelets, they got peptic ulcer disease. That's not dengue hemorrhagic fever. Dengue hemorrhagic fever should come in with capillary fragility, should come in with capillary leak. Are you understanding? वो सब नहीं रहेगा तो you can't call it dengue hemorrhagic fever. समझ में आ रहा है? Dengue kills only by hemorrhage? No, it actually kills the patient has a sort of shock. So he's not going to die to bleed to death. He's going to have shock and he's going to die. Microsurgical damage and he's going to die. You understanding? Poor management turns dengue into dengue hemorrhagic fever. Can be more poorly managed dengue can become more severe. But dengue hemorrhagic is completely distinct. It doesn't move from dengue to dengue hemorrhagic fever. Dengue hemorrhagic fever is something. Dengue fever is something. You don't move from here to here if you don't manage it properly. It's a distinct symptom. Even well-treated patients coming to the hospital can have dengue fever and die. That's the case that happened in the Barbara hospital. Patient was normal. Patient's platelet counts were 20,000. Patient was in Leelavati. Okay, and next day patient suffered very badly and died in 2 days' time. So a well-treated, well-observed patient can also die with dengue hemorrhagic fever is what you must understand. So when a patient comes to the ICU, don't tell them he's okay. We hope that he remains fine. Because even a well-treated person, a well-hydrated patient can still go to dengue shock syndrome and dengue hemorrhagic fever and die. Clear on this? You always hold it very carefully. You must be very careful. Do not just say patient is okay. No, patient is not okay. We hope that patient remains okay because there is always a possibility suddenly going to dengue hemorrhagic fever. Because patient otherwise is normal, talking to you normally, and suddenly next day you say patient is going to require a ventilator. You got the point? That is how it is. Tourniquet test is actually very non-specific. That's why I said let's not look at tourniquet test as much, but you can do it because it's nice to see something with yourself. You can see it with your own eyes. Okay, it's not a pediatric disease. People think pediatric everywhere. It's not. It's not a disease. It's all over the place. It's not a low income. It is in fact high income group. In fact, this occurs in closed environments. This is one of the mosquitoes that like to remain indoors. Aedes aegypti, Aedes albopictus wants to remain indoors. So indoors is where they grow more. Indoors is where they remain, and they bite you in daytime. Okay, they bite in daytime. So it's not that it is low income families. No, it is high income families also get it. Right? In fact, they will get it. Tourists will certainly get dengue hemorrhagic fever. No, it is not like that. Okay, it is not this way that is because tourism will stop. If you want to go to tourism will stop. It's not like that. Okay. There is at the moment no vaccine, but yes, there is a vaccine that is coming in the United States. Very soon that vaccine will come to India also. At the moment in India it is not there, but the effective vaccine is coming up. It has already finished its testing periods in dengue in abroad, and it is probably going to come in India very soon. That will make our life even more miserable. Because now you see IgA very differently. As of now, vaccine नहीं है इसलिए आपको पता है IgG ऐसा हो रहा है, IgM ऐसा हो रहा है. Once the vaccine comes in, we get IgM positive because the vaccine will cause IgM to go up. So it is going to make life difficult if the vaccine comes inside. Of course, but we want the vaccine because we can save lives. But then there will be a new interpretation to our tests of IgG, IgM, something different that is going to come in. So it will definitely come in is what I feel. So that tetravalent vaccine is there. That is probably going to come. That is tetravalent vaccine because issue is that it has to have viral interference, immunogenicity, reactogenicity. These three things are going to be an issue. I feel. Of don't know how it happens. It assumes that neutralizing antibody is the main factor of protection against dengue infection. This is the problem with the vaccine development. Okay, potential immunopathogenesis, including antibody-dependent enhancement. These are all the potential problems. And of course, when the dengue fever comes in, vaccine comes in, we should need long-term follow-up. Also, baki hai, long-term study. Like COVID का हमारा long-term study we just took it. All of us, we all took the COVID vaccine, right? But we do a long-term follow-up. Vaccines actually, after you take it, so you have long-term follow-up. What the point? COVID का हमको पता नहीं हमको क्या होने वाला है. None of us know क्या होगा हम लोग long-term. Ideally, you take a vaccine, it has a long-term effect, right? अभी तक मुझे तो पता नहीं है, but COVID was so bad, it was killing so many people that we decided to take the vaccine. Okay, so long-term follow-up will be required for this vaccine because it's not something that will kill and immediately kill, wipe out the generation. COVID was something going to wipe out the entire country, wipe out the entire world. That is why we had to take that virus vaccine. It needs to be tested both sides, Americas as well as Asia. So the Americas testings are, I think, done. I think so.